This is a company that's bringing organ restoration to these critically ill patients, and I'll walk you through what that really means to the patients that we treat today. Obviously, we've got forward-looking statements that I refer you to. Maybe if I could start with a story. In December of 2016, we treated our first pediatric patient. She was about 13 years old. She went in for spinal surgery. It was elective. She was allergic to propofol. She went through 6 organ failures right before Christmas. You can imagine what the family was going through. This was our first patient that we had treated. What you'll hear from the outcome perspective, which was the basis of our approval, was that all 6 organs repaired themselves. She was released from the hospital right after Christmas and went back to school, not on dialysis after her kidneys had failed. That was the basis, one of the 22 patients that we had treated, which was the foundation for our product that is approved now by the FDA under a humanitarian device. So we are a commercial stage company, and I will walk you through what really this means from an extracorporeal solution standpoint and this whole idea of a cytokine storm and restoring organ function. I'm actually joined here with David Green, our CFO, who will kind of give some comments at the end. But the leadership team has great experience across the board, which you'll see from Chinook, Amgen, EY, et cetera. This is a platform technology. And so if you think about it from that perspective, it's a highly leveraged. You're going to see a lot of safety data, clean safety, but that safety data then can be leveraged across the multiple indications that we'll talk through a little bit. This is a proven delivery system. We use a current infrastructure that's already out there. We are actually a unique device, is what they would call us. It's actually overseen by CBER, the Biologics Division of the FDA. So you have to scratch your head as to why a device would actually be overseen. It's actually doing autologous cell therapy in real time. And we're actually transforming immune cells in real time, in series. And so that's why we're actually overseen by the Biologics Division. It's not mechanical. We're not filtering something out. We're actually changing the biological composition of each patient. It's also shelf life stable at room temperature, and it's got a shelf life of 3 years. So when now you think about the uniqueness of this, I see some curiosity in the audience as to how this is actually done. We'll get a little bit into that. It's the same device that's used in all these indications. So it's highly leveraged from that perspective. We're really just now doing clinical studies to expand the indications. As I said, we have an FDA approval now in children. That actually has an indication of sepsis. So that's acute kidney injury patients with sepsis from 10 kilograms and above. The product name is Quellimune, which is essentially what it does. And then we shipped that product in July of this year. We now, for the SCD, or Selective Cytopheretic Device, we now have 4 breakthrough device designations through the FDA. I think we are probably the only company to actually have that moniker. Most have 2. This has broad indications, and you'll see through the mechanism of action how it works. We're starting in kidneys. Pediatrics was where we started, which is where we got the FDA approval for a humanitarian device exemption. We're running a clinical study, a 200-patient study in adults, which we'll talk about where we're at from that. One of our partners now has a grant through the NIH for cardiorenal, so that'll fund the cardiorenal with a bridge to LVAD. That's about a $3.6 million grant. Hepatorenal, so that's when your liver as well fails. And then most recently, we expanded on the chronic side. So chronic dialysis is another large market opportunity to be able to help potentially improve the life of some of those from a quality of life perspective. And then you see lungs are on the list for as well. We are covered by 40 U.S. and foreign patents as well. So the 2 lead programs, as I said, are in kids. One in kids with that has been launched, and then the other is on the pivotal side with an adult AKI. This gives you a little bit of a sense, a little bit more kind of under the covers. Is how big is the opportunity? Is this a $5 million opportunity? Is it a multi-billion-dollar opportunity? I think what you'll see here clearly is what we've done for our investors is to kind of start to outline how big is it? How much is it going to cost to run some of these studies? How big are the studies? What's the timing? As well as what you'll see here is we're estimating the kind of peak range of sales in the $2 to $2.9 billion range. which that is within the next 10 years. How does it work? So let's first start with what causes it. So as you see here on the left is infections, injuries. So if you think about like viruses, bacteria, surgery, trauma, all of these things can actually initiate an inflammatory, like an imbalance in the inflammatory system. That is essentially where we're starting, okay? So it starts, and then what you have is what we would call our first responders. So these are neutrophils and monocytes. They're going to the sites where the injury's at, they're flooding there, they release these things called cytokines, which we've probably all heard of cytokines. They're mediators or things that are kind of communicating that, hey, more folks need to come and help with the infection. Then you have this thing that looks like a tornado, that's a storm, and that's what's the uncontrolled cytokine storm because it just feeds on itself. And that's usually what happens when the patient gets to that, is it starts destroying actually good tissue and good organs, and that's where you start to have organ failure. Pharma companies are actually looking at each one of these little dots. So if you look at each one of these in that cyclone, that's actually, each one of those is what the pharmaceutical companies and biologic companies are doing. We look at that as that's an interesting approach, but it hasn't had consistent clinical results that have actually shown that it's efficacious, especially within addressing the cytokine storm. And we'll actually talk through how we're different on this slide. So if you look at it again, a little bit of a depiction, I'm going to just kind of highlight here that this is where the injury starts. Here's where the first responders come in. This is where that cytokine storm is. This is where we target. So what we're actually able to do is pull and sequester the most highly activated neutrophils and monocytes. We create a microenvironment where they normally like to hang out. So same flow rates, they think that they're literally tricking them to bind to the fibers of the inside of our device. They stay there in a low calcium environment. They go through what we call apoptosis or cell death. They're then dissociated back and they go back into the body and they signal that the storm is over. That's actually how it's done in real time. This gives you a little bit of a sense of what we're actually doing. I'm not going to go through all the details, but this gives you a sense of the level of science, of specificity, of actually how it's doing what it's doing. And so this is the fingerprint of actually how it is being this continuous cell processing and of these circulating neutrophils and monocytes. It is really important to note that there's no immunosuppression. Okay, we actually did a COVID-19 study where the standard of care was corticosteroids, high-dose steroids. It works the same way. Actually, we reduced mortality rates in that patient population from 81% down to about a 31% mortality rate, so a reduction in mortality, which was substantial. And on top of it, what we're seeing in our clinical data, which we'll talk through, is not just the reduction in mortality, but also really the repair of those organs. You look here, this is a patient, and this is the standard of care. You see a hemofilter comes in. Normally in the standard of care, it goes through a hemofilter, removing toxins, and then returned back into the body. This is the SCD, or quelimune for children. This is what I was describing, which is, this is a simple addition. It takes about 15 minutes for the clinical staff to actually implement this. It's a disposable model, so every 24 hours it's replaced. And it leverages the current infrastructure of pumps that are already out there in the intensive care units today. So if you are a hospital system, you're not having to bring on great big capital equipment because you actually are already sitting there in that intensive care unit, which makes it extremely attractive. The clinical evidence. So here's a little bit about the frequency of patients in acute kidney injury in children. About a quarter of the patients that come into the ICU that are children have acute kidney injury. They stay in the hospital twice as long. It's a coin flip, unfortunately, whether they live or die. And when we talk about mortality, we don't talk about mortality in terms of years. We talk about mortality in terms of days, because that's how fast these patients will actually can actually go through and end up in mortality. And those that actually are able to survive, about 30% actually have long-term effects on top of it. So their bodies have not actually repaired. and they may be on long-term dialysis for the rest of their life. So what have we been able to show? Well, so I talked about the 50% standard of care survival. We've actually shown 77% in total. Here you can see dialysis dependency. About 10 to 30% of those patients are actually long-term dialysis patients that will now have to visit either clinics for the rest of their life and deal with the consequences and poor quality of life that goes on. This is what we have, 0. And you're going to see that this whole idea of 0 or very little is a common theme, not just in kids, but also in adults. And then on top of it, we have seen no device-related infections, immunosuppressants, SAEs, or serious adverse events, etc. So this is the summary of the pediatric study the data that I just presented. What you'll see here is in adults, it's the same pattern. So we've now done about 5 or 6 different studies. We see the same thing, which is in all cases essentially cutting the mortality rates in half of what the standard of care is, and no patients on long-term dialysis at day 60. This gives you a little bit of a sense of the safety profile as well. You can see that this was before the adult study that we're conducting. About 800 and so devices that have been used, almost 20,000 hours of continuous use. Again, goose eggs on the right as to the level of safety here. So in children, as we're just now launching, really the target here is to really focus. So there's about 200 children's hospitals that are in the United States that are within kind of the sphere of what we need to go to. About half of them will treat about 50 will treat about the top 50 will treat about half of those patients. And so that's really where our focus has been. The goal was to hit around 4 to 5 patients by the end of this year, and then about 25 by the end of next year. We're actually now shipping directly to those hospitals with a very small sales staff, so this isn't something that we have to bring on a lot of sales teams to be able to do this, to go and actually sell on a daily basis. And so it's not like a pharmaceutical sale, it's much more on getting humanitarian device exemption or that through investigational review boards or IRBs. Once those IRBs approve it, then it just becomes more of monitoring usage and those types of things. The value proposition in children is quite clear. If you look here, the total mean hospitalization cost for the DRG is well over $450,000. And we're projecting that on top of it, we'll be able to lower those costs by about $30,000. You see here on the bottom, this is what it's going to cost the hospital systems, which is about $10,000 to $30,000. So really an unbelievable payback. When you look at the studies as a whole, on average, when we did our pediatric studies, it was about 6 days of treatment was done. We did and presented this data at American Society of Nephrology, but at $3,750 a day, which is per device, it would take 8 to 10 days for there to be cost neutrality. So we're already kind of projecting that the hospital's actually making money by actually using this. So it's very much on not only doing that, but they're saving children's lives. On the adult side, we're in the middle, as we said, running a pivotal study. So this is a PMA study. And it's important to note that's actually the one study that's needed to be able to get full approval in the United States in adults for acute kidney injury. It's a randomized controlled study. You can see here it's got a control, which is a standard of care today. It's a short endpoint, a hard one, but when you see the data on mortality and dialysis dependency that I showed you before, it's the right one. We're not using biomarkers. This is about actually, is the patient alive or dead, and are they on dialysis or not at the end of 90 days? And it's a composite endpoint, so it takes both of them into account. Also important to note, we estimate about 50 to 60% of these patients will be septic. So while this is not a sepsis trial, the majority of these patients are septic. Actually, all the clinical data I showed you before, 50 to 60% of those patients were septic, which is why we got the label from the FDA for kids that sepsis that we could treat those patients that had acute kidney injury and sepsis. That's a very important point. Where are we at today? We announced a couple days ago that we now have actually 65 patients, so we're just nearing that third mark. It's now also, we had brought in another site, so 13 of the sites. It is a mix of not only academic, but also military and community hospitals. You know, as we talk about the size of these opportunities, so in children, it's about a 4,000 patient opportunity in the United States. In adults, 50 times, or about 210,000 patients. That's important because you can't focus just on academic sites if you want to get all the patients or get access to 210,000. And so by having this broad group really does show that its ease of use, how it's actually used, etc., getting sites up and going shows the broad utility, and that really will help from an adoption when it comes to the commercial side. We will be doing an interim data review after the first 100 patients, so as you can see, we're inching our way there. And then we'll have that data about 90 days post-follow-up. We have to wait 90 days to do the final, whether there's mortality or dialysis dependency. And then we'll commercially launch that sometime probably late in 2026 after approval. It's also important to note that we have CMS reimbursement for Medicare patients on the study. So what this means is that for those hospitals that want to, they can actually submit the cost that we'd normally be paying. They can submit it to CMS and be reimbursed that way. It actually really benefits the company that we don't have to put that kind of cash out for those patients. And what we have seen is it does increase some of those site activations because it's mandatory for some sites that they need to have that in place. And so it's really helped from accelerating that subject. But we're not stopping there. This is not about just a kidney play. This is actually much broader than that. This is a multi-organ play. This is a multi-indication play. And the way you do that is you have to educate medical professionals, not just in kidneys, but in all facets, right? So the intensive care unit has a lot of folks that are coming in. So we do a lot of stuff, research with the University of Michigan, which is also a co-owner of our patent estate. We have a deep scientific advisory board of not only pediatric nephrologists, intensive care, adult. It's really a broad range, also basic science. We do a lot of presentations, scientific, published manuscripts, which we can get you that. Case studies, compassionate use, all the things that really you need to do to really show and demonstrate, which takes time. You know, it's not something that you can just do overnight. This is an investment that a company has made. And we're going to continue to expand in a lot of these indications. As it is a platform technology, we have a very clear criteria. I mean, obviously, you have to look to see where neutrophils and monocytes could be the culprit. That's where you start, and then you start going down. And you know, the opportunities that we've seen thus far, the mortality rates are so high in some of these. I mean, you think about hepatorenal. So when your liver and kidneys go, your mortality rate is 60, 80%. I mean, you're kind of done. And so those are the things where you don't need large studies then to actually be able to show statistical significance, which means less capital needs to go in for the same large market opportunity. And these are things that we believe that are going to be very challenging for a pharmaceutical company to actually even start to think about, because neutrophils are very ubiquitous. It's not something that you can just take them all out, because you do need them for a lot of the balance. And so that's where it really becomes something very unique of how this actually works. And maybe, David, if I can get you to come up and wrap up on the last few slides in the last 6 minutes.
Okay, thank you, Eric. Good afternoon, everybody. I'm Dave Green, CFO. As you can see, the ticker symbol is ICU. Pretty easy to remember since we treat patients in the ICU. And this data is as of November 1st. So $3 share price, 4.4 million shares outstanding, a market cap of about $13 million. All of that with an FDA-approved product, a pivotal study in place, ongoing, 1/3 of the way complete. Amazing data. We save patients' lives and we save hospitals money. So looks like a good investment opportunity. We've got some warrants outstanding. They're on average, they're pretty far out of the money. And just recently, you'll see we have paid off all of our debt. Just advance. Okay, so 2024, we did a lot of work to clean up the balance sheet. As you can see, we paid off all of the interest-bearing debt. And again, we've got substantial asset value under this $13 million market cap investment. We've got the FDA-approved product that we just launched in Q3 of this year. We've got our pivotal trial, 30%, 33% enrolled now. We're 2/3 of the way through to our data readout in 2025. We've got 4 breakthrough device designations and multiple high-value indications to pursue, all with, investment for the studies fairly low relative to pharmaceutical companies. On the commercial side, we've initiated sales in Q3. We've got 3 hospital customers so far, and so that will be expanding as we move forward. We've got a small sales team. We capture 100% of the margin now that we are the distributor for the product. And we've got a clean capital structure, and we use capital efficiently. Okay, going forward, looking at catalysts, why should you invest other than the low value with a super high potential? We've got a top-line data readout coming soon. We're 65% of the way through to that, 100 patients, so that'll be the first half of 2025. We should hit our 100 patients and have the data readout roughly 90 days beyond that. We will expand our hospital patients from 3 today to 20 to 25 next year. And all that with our in-house sales team, which is 3 people. So again, fairly efficient. And we'll initiate the new pivotal trial for cardiorenal, which we have the grant funding for already. And there's probably additional breakthrough device designations in the future. So all of that next year. We've got additional activities in 2026, which will continue to add value, especially an expected PMA approval on the adult side, again with 210,000 patients out there in the US alone. With a small portion of those, it's a very substantial revenue opportunity. So I will stop there, and we can take some questions.
Yeah. You keep talking about the platform, but maybe I missed it. I don't understand exactly what you do to the patient. Is it a machine, a pill? In other words, if you're doing it to me, what do you have?
It's a device. It's a one device that's used for adults and children, as well as it's used for all of those indications that we mentioned. So it's a device that's hooked up online to equipment that's already existing in the ICU. So it's a device that does cell therapy. So your blood will have cell therapy applied to it if you're hooked up to our device. Is that clear?
Yes.
Okay.
Question for you.
Yes, sir.
You mentioned the reduction in the number of patients that are on dialysis at the end of the treatment. Could you, do you have any numbers on mortality and survival of these patients when they're on dialysis? If you're reducing the number on dialysis, that would have implications for them after treatment.
Yeah, so this is reducing them to go on dialysis.
Right.
Initially, we through our chronic dialysis breakthrough, we're actually working with the FDA on designing a study to address chronic dialysis. So those patients that are on dialysis, can we improve the quality of care, nutrition? Can we actually bridge them to a transplant so that they don't have to? Because much of what chronic dialysis is a very inflammatory process.
Yep.
And so if you can actually take that out or take it down or reduce it, you may actually be able to bridge them on top of it over to a transplant, or even get additional dialysis treatments in. Because part of what the problem with dialysis patients is that they do it 3 times a week, and that's all they can tolerate. because it takes that long for their body to recover in between those dialysis treatments.
So freedom from dialysis would be a substantial amount.
100%.
With more than 6,000 small and micro-cap companies listed, if you're looking for the next Apple, then Channelchek truly is your tree. It's an investor community where you can access independent Wall Street research, advanced market data, balanced news, corporate videos, and podcasts. You can even register to attend in-person Meet the Management Series lunches, and to be part of the preeminent annual Small and Micro-Cap Investor Conference, NobleCon. And here's the best news. Since Channelchek is sponsored by the featured companies, premium membership requires no investment. It's absolutely free. So check it out. Log in today. Find out why Channelchek is North America's leading source of research on the companies that just may change the world.